Welcome to Cases in Clinical Medicine. In this podcast, I break down real-world scenarios to sharpen your clinical decision-making. I hope you find this helpful. Let's get into today's case. A 58-year-old woman with a history of systemic lupus erythematosus, hypertension, and gastroesophageal reflux disease comes to clinic with complaints of intermittent headaches and fatigue. Her labs show a white blood cell count of 4.7, hemoglobin of 8, hematocrit of 25, and an MCV of 74. Her platelet count is 544,000. Reticulocyte count is 1.5%. Her iron studies reveal serum iron of 45, a TIBC of 520, and a ferritin level of 20, and her soluble transferrin receptor level is 4.2. Given this information, which of the following interventions would provide the most benefit? Option A, erythropoietin-stimulating agent therapy. Option B, better control of her lupus. Option C, 1 unit of packed red blood cells. Option D, intravenous iron. Or Option E, proton pump inhibitor therapy. Okay, let's walk through this case. This patient has a microcytic anemia reflected by her MCV of 74. Microcytosis occurs when the bone marrow doesn't have enough iron to make hemoglobin, so red cells divide more times than normal, becoming smaller with each division. Her hemoglobin of 8 confirms a significant anemia, and her TIBC is markedly elevated at 520. TIBC measures the amount of transferrin made by the liver, and it rises when the liver senses low iron stores. Increased TIBC is a compensatory response. The body increases its iron-binding capacity to scavenge more iron. Importantly, TIBC goes up only in true iron deficiency, and it actually goes down in anemia of chronic disease, because inflammation suppresses transferrin production. Her ferritin is borderline low at 20. Ferritin normally reflects iron stores, but it's also an acute phase reactant. In inflammatory diseases like lupus, ferritin can appear normal or even elevated despite underlying iron depletion. That's why ferritin alone cannot be trusted in autoimmune conditions. The most decisive test here is the soluble transferrin receptor, which is significantly elevated. This receptor increases when erythroid precursors experience iron starvation. Unlike ferritin or TIBC, it is not influenced by inflammation, making it one of the most accurate markers for diagnosing true iron deficiency in patients with chronic disease. Another clue pointing to iron deficiency is her marked thrombocytosis, with platelets above 500,000. Iron deficiency stimulates thrombopoiesis through shared progenitor myeloid pathways, so elevated platelets often accompany iron deficiency anemia. Although lupus can cause anemia of chronic disease, her labs do not match that pattern. In anemia of chronic disease, inflammatory cytokines, especially hepcidin, trap iron in macrophages, reduce intestinal absorption, and suppress liver production of transferrin. This produces low iron, low TIBC, and normal or high ferritin. But the patient in our case has the opposite pattern: low iron, high TIBC, low ferritin, and high soluble transferrin receptor, indicating textbook iron deficiency anemia. Additionally, her GERD suggests chronic PPI use, which reduces gastric acidity. Acid is required to convert ferric iron into the absorbable ferrous form, so PPIs further impair iron absorption and contribute to deficiency. Given her significant, likely long-standing iron depletion and poor absorption, intravenous iron will restore her iron stores most efficiently. Here are some learning points of this clinical case. In patients with chronic inflammatory diseases, ferritin can be misleading. TIBC reflects the liver's response to iron deficiency. It goes up only when iron stores are low. Soluble transferrin receptor reflects the bone marrow's iron demand. It rises only when cells are truly iron-starved and is not affected by inflammation. And finally, a high TIBC plus a high soluble transferrin receptor is the clearest indicator of true iron deficiency anemia, even in autoimmune conditions. That's it for today's case. I hope this was helpful and high yield. Take care, and I'll see you in the next one.